my second postgraduate year, I was selected to do the Medical Service Improvement Program. I decided to apply as I saw a good opportunity to get involved in the clinical governance side of health. I've always been interested in leadership and organisational development, and so I was attracted to the skills and education that the program provided. After being involved in developing a student society during medical school, I saw the MSI program as a logical step for me. As a junior doctor working in a government department and working in a complex bureaucratic environment, it can be very frustrating, particularly when the problems and the challenges that you face seem at odds with delivering good patient care. You often feel as though you're fighting against a system in which you can never win, but in fact, you're working in a dynamic industry that is consistently changing and upgrading. You just need to find your way to the right place, and you need to meet the right people, and this program gives you that chance. The project started for me by looking for an issue in the hospital system and with patient flow. And as a surgically oriented person, I wanted a surgically relevant topic. So I chose to focus on the issue of patients referred to a tertiary hospital emergency department for a plastic surgery review and admission. These patients having been seen in peripheral EDs already. Many patients, especially with minor hand trauma, had to be re-examined by ED medical staff, by plastics registrars, prior to being admitted for surgery. This was thought to contribute to long waiting times, doubling up of medical assessment, and delayed time to theatre. Through this program, I was granted access to data from ED, hospital admissions, and the Department of Health, as well as working alongside the Department of Health statisticians. I learnt a lot about data collection and analysis, and I was able to gain extensive data to show particular issues. For example, I was able to demonstrate that plastic surgery patients referred from peripheral hospitals with minor hand injuries were spending nearly 8 hours in ED prior to admission. That is double the amount of time compared to a patient presenting directly to our tertiary ED. What's more, this results in close to $60,000 of medical wages and duplicated medical assessment every year. To that, plastics patients were waiting an average of 1.5 hours to be seen by a plastics registrar from the time of referral, and were waiting nearly 2 days for surgery at a cost of over $2,000 per patient per day. I had the opportunity to present this data to the executives of the hospital, to the financial committee and the hospital CEO, as well as the heads of department of plastic surgery and ED. And by doing this, I was able to gain support from the development of possible solutions to address obvious inefficiencies in the system. Following sessions with staff, I identified root causes and developed proposed solutions as to why it was taking these patients so long to get to theatre. There's an inconsistent referral process, duplication of medical assessment in ED, limited access to plastic surgery registrars, and inadequate theatre time. One of the biggest issues raised was the fact that more patients were being admitted every day for surgery than there was theatre time to operate on them. This leads to major delays and backlogs of patients who are often fasting for theatre for days and taking up an inpatient bed for up to 6 days for what should be a day case. This was most significant over the weekends. I proposed the development of a weekend procedure room clinic run within the hospital where patients with minor hand wounds would undergo procedures under local anaesthetic and go home the same day. This would eliminate a second ED visit, they would bypass inpatient admission and reduce the number of patients competing for operating theatre time, as well as reducing inpatient bed days. This was formulated into a formal business case with the business managers and the CEO of the hospital and remains pending. The other solutions included developing a hand injury admission sheet for use in the emergency department to achieve a more consistent referral process to plastics registrars. I was also able to help the plastic surgery department procure an on-call smartphone that appropriately collects and stores photographs of patients' wounds in lines with Australian, state and local hospital policies. With all these solutions, I got to develop a relationship with the documentation committees, staff members at every level of ED and the plastics department, and with the CEO of the hospital and executive committee. It was a challenging and varied project that had a large scope. I learned an enormous amount about how each person from junior doctor to consultant in each department across the hospital can have a direct impact on the overall patient flow from presentation to admission to surgery and to discharge. I learned a lot about how to quantify these issues and present them to a hospital executive. I had the opportunity to meet a lot of people from the hospital executive and the various behind-the-scenes people who all make the hospital function on a day-to-day basis. It was a hugely beneficial experience, and I would encourage anyone interested to get involved.